there's some pain here.
Yeah, then that's.
We got purple dude.
Wait, is this an easiest one?
Is that what we can do for you?
Fabulous. Almost there. Next one. Twos, circles, same position, forward. I like to cue with this elbow doing small circles. If they're having an issue, it's usually because they're wanting to do this. So I like to cue chest out, then go. If you've ever tried to take someone through this, and maybe you've had that this experience, there's times with NPA you fix one thing and then they do something else. I find that if you're going to cue and take someone through this, choose one, do like top to bottom. So start by fixing this, then go to elbow, then go to wrist. Because if you just move out, they want to do something like this or this. So this is one you really need to be comfortable putting your hands on patients, and if they're not able to like do what you're telling them, put them there, show them that, and giving the feedback of, okay, that was a good rep. That's how I want it to look. Each one needs to look like that. Then they know. That makes sense? So now let's go 10 circles forward, in, down, then we do circles back. And as far as the wrist being in line here, I like to just take the bands and pull them out. They usually do pretty well with that. Cue.
I was told when I was being a test dummy, or I was there when they were told out of Atlas and doing this training, and I was the test dummy while they were learning how to cue, that this is a therapeutic / neurological exercise, because you have to think about what you're doing and your form while you're doing it, and as the harder it gets for you, the more you have to focus on your form to do it right.
Yes, and it is like very enduring space, so you'll find like, cool, they got 1, 2s down, okay, form is starting to fall apart at 3s, and that's part of building your endurance. We don't expect it to be like picture perfect, but there's limits of that. Like, okay, maybe you do need to take a rest, maybe you can't go all the way through, or they need to do 10, rest, next thumb position, that's fine too. But as far as you guys and progressing them, totally feel free to do that kind of progression of like, okay, let's try and go all the way through, or can you do thumbs up and thumbs in without a pause? Or that's another way that we can progress that most clinicians, of course you can always ask your clinician, but most are like, hey, they're already doing it, that's just better programming. So, any questions with the forward, back? Okay, swims. This is one that I find that most people really struggle with getting the motion, and this is one that I find is the easiest to have my hands on them and show, because it is opposite like swimming. And they usually want to do too big of motions. Still same small circles, it's only about an inch right here and go. So now you guys go, I'll show you. If they're having a problem, sorry, we're right here, you're so good. If they're having a problem with it, I will grab both elbows and show them myself and do this to be like, okay, you got the flow. Next one I see is torso movement with it, and then I'll just cue, keep your shoulders forward. So we'll try thumbs up, thumbs in, thumbs down. And you gotta remember which one you led with, because then you do opposite. So we'll do both directions. Yes.
Wait, so is the motion just kind of coming from the elbows then?
Shoulder blades. Because if it's elbows, you're doing this. Does that make sense? You can-
Yeah.
Elbows is this, and they'll start creeping forward.
Think how much empathy you're gonna have for the patients that are doing this after this.
I'm losing blood.
Yeah, and it is a lot, and about
Very
here
nice.
is whenever you see people start doing the upper trap. You guys have been good thus far, not really doing that. That's another one that I'll put my hand down and arm up. So say if Corbin was being bad and doing something of this sort, I'll do this and this to say this is where I want you. So, any questions with the swimming?
Put down, is that normal? It's a little.
I mean, it doesn't feel great. It's end range of motion because it's using internal. All the thumb position is doing is putting little difference of torque, of like increasing the amount of internal or external rotation we're doing. That's why if you have like impingement or limited motion that doesn't feel good or can be painful, specifically in the front. If you have any kind of like bicep tendinosis, those kinds of things, and they'll say, I don't do thumbs down. Okay, yep, skip that, we'll get you better, we'll add it back in. So, that was a good question though. Any others? No? Okay, fours, saws. This is one that we are gonna change where the clip is at. So I like to, depending on how high they are, I like to have it maybe about head level or so. Yeah. And I think the big keynote with this is a saw is different than a row. Because on Andy's flow sheet, then you'll see modified decline row. So row is going from a straight arm, elbow bent, like bringing elbows to pocket, right? It's the same position on there, but a saw, I like to hold on here, you can do those, but a saw is down into an athletic position. Yep, good job guys. You start at your pocket, you go back and back to neutral. Should feel it all in your lats, right? You feel what I'm talking about? Especially if you're familiar with like at the gym, like a lat pullover, we're kind of just doing the end range motion with that. Anything with NPA, it's like 1 or 2 inch movement. So when you are showing patients, here's a saw, they want to do this, that's different and not traditional NPA. Also, I find that they have an issue of keeping the elbow slightly bent. See, I'm not rowing, I'm not here, it's not a tricep push down. I'm holding here, then go. So, if you can get them to get the elbow bend where you want it to be, then show them the 1 inch, 2 inch movement, they do pretty well. If you say, cool, come do your saws, you're gonna get a weird row to pull over rendition, and I think that's where some of the confusion is coming from. Does the distinction between those two things make sense? Fabulous. You can do the same thumb position. We don't traditionally do that as much here, but you can do thumbs in, like up, thumbs in, and thumbs down as well. So, play with the thumbs in and thumbs down just so that you can feel. Okay, next thing I need to show you, because I think that you all did it. When we are here and we're going back, I'm still keeping shoulder back, and it's my shoulder blade that's moving. I don't want this. See that? Where like shoulder, can you guys see that? I'll show you this. I don't want this, where the whole shoulder complex rotates and goes forward. We're stable here, back. No rotating. None of this. Bad. That makes sense? Good. Yeah?
Yeah, sorry.
You can disagree. We'll get into it, whatever. But that's another one, especially if someone is having pain while doing saws, or they're like, I can't do this doesn't feel good. That's usually the biggest compensation, is that they're letting their shoulder dip too far forward, too much rotation, instead of keeping it stable and coming back. Also, if they're having issues with it, feel free to bring the band down to whatever pressure they're able to tolerate. Make sense? Cool. That was 4s. 5s, press downs or like tricep press downs, back up to like head height. I will show you guys if those are okay. I like to have them hold on to here, but it's whatever their preference is. That just feels like stronger to me, but you can go here too. Elbows at your side. Yep. There you go. Technically, you can do like the thumb positions with this as well. The up, the in, down, not as much. There's a little bit of play there, or if you want to add a little bit of twist, that's within like NPA guidelines, I guess. The biggest thing that I see with this is sometimes too much of a forward lean athletic position, and you almost get into a saw type situation. The next is start from the beginning of having shoulder blade down, back, up. I don't want any of that same twist forward where they get about halfway, they shrug it up to get it the rest of the way. So, down and back, up.
And y'all will be surprised, you go through a whole series of those, and you will be surprised with the rank resistance on the soreness you accomplish.
Oh,
In your triceps or glutes.
How are you feeling?
Huh?
How already feeling?
Yeah, it's, you kind of go, oh, darn it, that works. And you're on purple.
Yeah. Well, and if it isn't, then you take out the rest breaks, like what we talked about. Like, okay, we don't do the reset, we do the full 30. Yes, we're on to 6s, which is internal, external rotation. We usually here have people do one arm at a time. I'll show you like the NPA specifically, and that's gonna be one hand holding, one hand less. I like how you all did one longer and one shorter than the other. That helps as far as getting it out of the way. Whichever one that you're working on, say on internal, this is just isometrically holding. We want it to be at that 90-degree bend, so not here, right in the neutral, and then we do internal. So 10 thumb up, 10 thumb down. So we get all of our thumb positions in. And this is when we can do thumb out. That's our first. We got in, down. We can't quite do in with internal rotation. It all just hits a little bit of different fibers. So gold standard is 10.
I have a question on the internal and external rotations. And this is, I got drilled on these over there to have the elbow slightly out, start at the belly button and come up a level, and go down and up a level. Is that?
If they have the external rotation to be able to go through that motion, yes, that's gonna be more like month 3 or so after a post-op, because it just depends on how much motion you have. But that can be a good way to progress. Say we start with just at the elbow side, right? And then say this is getting easier by doing that, then you're loading the cuff more through the full range of motion by changing the angle like that.
Got it.
So,
Got it.
and you guys already switched to other side, fabulous. Then we're just isometrically holding internal rotation.
It's not a camp.
Feeling it? These are differently, different in the cables.
So you're,
It'll be easier and then harder as you go out. It's like it feels easy until I'm at the end range of it. I don't like the way that's. Oh, thank you.
okay. Yeah, and everybody experimented with the thumbs up and out. Fabulous. I think we're okay for sevens. Reverse saws, which in the past there's been some confusion of like, what's the difference between a reverse saw and say like a chest fly? For that, I want, I'll show you, I guess. Reverse saw is more up and in front, but it's gonna be angled down more, even that, I would want lower. I'm keeping elbows in at my side. I like to have the band on the outside of the arm, or like right underneath elbow. We're here and going up. The lower you have this band, the more it's gonna load their front delt. When you first introduce this with someone, they're just getting to the point of getting beyond gravity and able to raise their own arm up. So you're gonna end up being more in here for them to be able to do it and accomplish, knowing that we're gonna work up to more and more resistance. So, and it's more of a uppercut motion of up. That's a reverse saw. A fly, I would go a little bit wider, a little more abduction, and like we're going around. I'm still getting an up motion when I do a fly, but see how I go back and get more of a chest stretch? That, to me, is way more fly, reverse saw. See the difference? It's subtle, but.
More like chest versus front delt.
Yes, exactly. The saw, we want more front delt.
Okay.
So, try it out. As far as cueing or helping someone with that, it's all about elbow position, because they're gonna want to try and cheat, especially like post-surgical whatever, and go out. If they have too much abduction or out, it becomes more of a fly. A true reverse saw, elbows at our side and going up. Yep, good. Good.
That burns.
And these, you can do the same, thumbs up, thumbs in, thumbs out. And those will hit different fibers. Some just like food for thought. For the thumbs out one, depending on if they have biceps issues, can elicit some pain, because then they're doing like an isometric bicep hold and loading that way to go up and do like that. You feel that what I'm talking about? You're like, okay, I can feel it a little bit in the front. There comes a point where we need to load it, but if they're having pain with the thumbs out, that is always a, like, ask your clinician, are we cool that we're loading that way? Are we okay for bicep loading? Yes.
So that
When
one,
in doubt, ask, right?
so that one, we can go thumbs up, in or out.
Yes. And the gold standard would be doing 10 of each, no rest.
So when you see like they're doing 1 of 30, they're doing one set of 30 on the like reverse saws or saws, talk to the clinician about whether, is that you want them all thumbs up, or you want to try doing them 110 thumbs up, 10 thumbs in. I haven't ever seen them do them thumbs down here. But I have seen them where they start doing them thumbs up and thumbs in. But it never hurts to ask. And when you get to somebody who's like getting at the end, then you get some of these people that are athletic like Lisa and some of these guys that are, some of them, they're all about progression. They're all about wanting to progress.
Well, I'm more familiar with NPA too. If you just go through someone the first time, never seen this can be a whole appointment. A whole appointment, and like can be just NPA, where we usually try and like phase them into it, so that one, we can see how they tolerate, because this is very isolated rotator cuff work with the only small movement stability control, and most people don't train that way and don't know how that feels, and it's kind of like shock to their system. To Becky's point of like the thumbs up, thumbs in, thumbs down, yes, that is gold standard NPA. We our population. Some can handle that, some can't. Blair has a term called NARP, so like non-athletic regular person. Sometimes they can't think of multiple things at the same time. Or you know that we have to work up to that. Not saying that a non-athletic regular person can't do athletic things, but there is a progression into that. So that's where you guys can help us of like, yeah, you've done NPA 4 times, and you've done good, and you can somewhat have okay for it. Yeah, let's throw in some thumbs in or thumbs down or whatever. And, I think that we're all okay with you guys doing that. So that was a good segment. Any other thoughts on that?
If someone's a regular person but they're athletic, what do we call them?
ARP. ARP, baby. We appreciate that. But you've been there with someone where you're like, I can't even talk to you while you're doing this because your form goes to shit, okay? Like we can't. So, even then we work into that as well, where you're like, okay, they know how to do it, their body is familiar with it, then we can build on top of the baseline that we've made. Are we ready for 8? Okay, 90-90. We're gonna do internal and external rotation. This is gonna be about shoulder, elbow height. We're going back to more that traditional NPA position, wherever you want.
Oh, wow. Yeah, we had that one.
We
That was a
yeah.
weird, I don't remember it. Yeah.
Like this is different. So same gold standard of 90, 90. We're here. Corbin's got it. We're going back and down. So this is external rotation. The slower you go, the harder it is. There is no thumb positions with this. The thing that I see with this, which is also hard for myself, is making sure that they don't drop into a W. If you're familiar with like a W pole, it's not that, it is rotation through. I know I don't have full motion, so. Yeah, Corbin's got it, he's good. Big thing is just having no elbow drop, and if you were to look down, it's all in line, no in front, is the gold standard. However, if we are introducing someone to this, and they are getting any kind of impingement pain, that is a modification to go here. The big thing is I don't want any side to side movement with this. See that?
Yeah.
No, none of that. Whatever, if I'm here or if I'm here, I'm only rotating. No back and forth with it.
Not like this.
Yes, that's where the W comes in.
Okay.
No W.
We look like this with the elbows.
Yes, I would even go elbow a little bit more. Go there, no. Yes. Harder than you think. It really makes you keep end range. So there's a reason it's the last one. So that's 90-90 external rotation. We're gonna flip, same position. We're up, and now we're going internal. Sometimes, depending on their height and such, we could bring down the band one rung. If we feel like it's snapping back too much. I like how you said back for him, that was good. Good range. Yeah, Carson. But this is one that I find that regardless, at some point, you're gonna have to cue them to put elbows up. Solid.
My gas truck. Should be on. Gas truck would be easy.
So that is traditional standard how it's supposed to be run through. Because NPA stands for like National Pitchers Association. This is supposed to be a warm up for being able to pitch and to be able to go through it with no breaks besides moving the band in between. So it builds a lot of stability and endurance that you would then use. For throwing, as far as upgrading it in general, you can place the patient on like a Arex pad, Osu ball, so that it's a full core and keeping yourself stable as well. And that's a great way to teach like shoulder and core to work together, get some like anterior sling work. Those I would say are more like someone who is going to go back to throwing or those kinds of, maybe like some track and field type stuff, and maybe we'll throw that on. And then downgrading in general, of course we have like the different bands, but if they're struggling with the purple and we still wanna get NPA, then I just, more breaks. There's some people that I'm like, okay, do 5, rest. We got to 10, you know, 5 with good form, rest. But with this, we care so much more about form and doing it properly than say like, okay, you did the 10 with all the thumb positions straight through. So, yeah.
Can you walk me through the anti-rotations or pallet press to the ones where like, it's not part of the MPA, but it's a big one that we do a lot of?
Yeah, so with this, I like to have it about elbow height, so whatever that is for you, let's have you adjust your hand. And depending on patient strength and such, there are times that we tie it off when we just have 1. 2 is going to be more of a direct load, so let's go over 2. We're gonna stand perpendicular to it. We're gonna have it right at my belly button. We're gonna go down into an athletic stance, very much like our iso squat. So I don't want anything onto the toes. We're gonna load the glutes by going back. As they breathe out, and they already should have worked on like curl ups, that kind of thing, so they should know what you mean by like engage your core. But if they're doing something like this, they're not doing that right. So ribs down, cue for the core. As you breathe out, straight line the whole time out and back in. The slower you go, the harder it is, right? So help them find what's doable and where they can have good form as they go. The big thing I see with this is bad foot placement and bad hip placement. What I mean by that is they're not keeping tight control, and as they go, they're doing something like this, right? Or they're not used to even squatting, so we're getting weird toe stuff. So the secret sauce with this is like a good setup first. They don't even start a press until we have their feet exactly how you want them. They're down into it, their knees are out, a little bit of forward chest, like so, but open. And then you turn into other side. And you will see this called anti-rotation or Pallof press. Pallof press was the guy's name, and anti-rotation is your resisting rotation.
You doing it mostly like, so like I'm facing this way and pushing more. I feel it more like on that side.
It hits a lot more of like side of core, QL, that kind of thing.
Okay. That's what your people said.
It's supposed to be more like an ab, like a go.
Yes, hitting core specifically, but it's teaching you to keep your 360 core the whole time. Most of the time, back patients have a hard time of, okay, overactive paraspinals back wants you to do this, and it's used to compensating for that. So, yeah, chest position and rib position being a big thing to watch there. Because if they're having issues, especially if they're down into it, and they're going, they're like, I'm getting a pinch right above hips, right in that low back area, guarantee they don't have their ribs stacked. You know what I mean by that? Ribs stacked? Yes. And those are all things you can look for and see and keep.
When you highlighted the curl ups before, I didn't know there was any cues to get on this here.
Oh, like with the curl up?
Yeah, like the samurai ball.
So if you come to here and you can tell they're having a hard time, how do I contract my core? You say, the same way you do with the curl up. Is what I meant by that.
Okay.
So yeah, when they are doing like a curl up or the samurai thing, you kind of want to look at them and be like, okay, engage the core when you're doing the curl up. You just want to stress that they're focusing on the abs. They're focusing on engaging those abs when they do the curl up. Because that's what they're working when they're doing the samurai chops or the curl ups.
And really us moving from like a curl up to this is great. We've taught you how to put all those pieces together on the table. When you hurt your back or have these issues is when you're standing up and you're up and about. How do I teach you to be stable like that in a more functional standing position? That's the progression. That's why we then go on to stand. Yeah, great question, great input. Do you have anything else in that list? You said lubrication.
No, I think that, press downs, we did the tricep presses and, press downs. Decline rows, are you guys familiar with how to do a decline row too?
Yeah, we're going over the difference between that and a saw.
Yeah.
But do you want me to specifically go over a decline row?
You guys
That
are
works so
comfortable with
much.
decline, just say it if you're not comfortable with, if you say decline row. Or modified decline row.
I'd love to see it.
Okay, here we go. I like to have it about head height, modified decline row. We're gonna do 0. Enough resistance to where it's out in front of them and they have a little bit. I don't like to go from no slack to slack. That's where you get a lot of this like bungee back and forth. Have them step out enough to where there is some tension on the board. We're gonna think of shoulders engaging more like rhomboids in between, and we're squeezing that pencil in between our shoulder blades. Another way that I like to cue this is elbows to back pockets. That's how you keep them in line with the band so that they don't do that anterior shoulder dumping of something like this. If you cue elbows to back pockets, then they'll get more of a full posterior chain and it makes them slow it down too. So, I think the only thing that I really see with this is people being too close and doing something like this. And then besides that, just like it does. Any other thoughts on
Will we ever do like a variation where we're like, what is getting like the
that?
upper
Yes,
back?
and he puts that as high rows, that's gonna be more.
So
rear
high rows
delt.
or, okay.
Yes, high rows are whenever we are in that same NPA position, but rowing. And so that's a full range of motion. So I want them to be able to go from pretty much elbow straight to back. That's different than NPA here because I'm just 1 inch movement, right? So this is going from scapula and shoulder blades almost being forward, right? Like that's my starting position. I want them to be theirs. And then full range. Higher.
So some contractions okay.
Yes.
And then
Mhm.
still the full.
Yes. That's a great question.
Will they be kind of more like this or kind of just, like, how should they, how would it be?
Back to our usual 90-90. So if everybody saw what Corbin just did, go back to what you did before. How much higher does this shoulder look than this shoulder right off the bat? And also, if we were to think of where his shoulder joint is there, it's higher than where his collarbone would be. So that's why I'm gonna have you be about there. That's more in line with shoulder, collarbone. I'll cue him to put up like that. Yep, now you can row that. Does that make sense? That's a good question too, even, sorry, Connor. Well, we also know you have shoulder stuff, so take it easy. But, that's also a good eye, cue for as far as NPA as well, like, okay, where's 90 for them? Where their collarbone is and going across. Because sometimes, especially if they have delts and such, then you're like, okay, where's your bone in there? Like, so, that was a great point.
I'm quote.
Yeah, go Corbin. Thanks for being capped, dude. You're helping out. Let us know what to do with that. Yeah, those are kind of my thoughts on that. But did you have anything else?
No, feel like you learned something?
Yeah, that was good. You brought up like emphasizing form, so like do some exaggeration here. Is it okay if I say patient's name?
Any patient's name and use me as a testimony if you want.
Okay, so like Cheryl, for example.
Yeah.
Or just someone that is maybe more than Mark
Yeah.
that you brought up. Do you want me getting pretty strict? Because then sometimes I feel like there's been a vibe sometimes when I'm watching clinicians of like, with this person I'm gonna be pretty strict. With this person, functional for you who looks like this. You know what I mean?
Great point. I think, and I'm going back to like my own tech experience and like, and such, that I feel like I ask them once to do it. I put my hands on you to get you there. You get maybe one more time, and then I'm gonna ask the clinician of like, or it doesn't even have to be an ask, you know we're down here, I make the eye contact and I do a little, we good? And I'd be like, that's good, you know, cause it's really up to, no, you're good. It's really up to like clinician, but someone in that situation of like specifically Cheryl, we know we have some patients that have good days and bad days. Physically, but mentally as well, where you're like, hey, if I keep cueing you, you're gonna be pissed off, and then we're not gonna have a good appointment. If you feel like that's in jeopardy, no, then we take what we can get. But as far as what I do to, like, okay, I gave you every opportunity, because at the end of the day, it's them and their choice and their ability to go through it, and we need to be respectful of like, hey, some days we have it more than others, so for me, I like to verbal, like, okay, let's see if I can talk you through it, physically put you there, and then one more time, and then I would ask clinician. And I think everybody's good with that. Most of the time you get them within those first 3.
Sometimes you gotta read the room a little bit.
Yeah.
Some people you talk to a little different than others. Some people you can cajole and like go like full on high school football coach to encourage them to do stuff. And like, what the hell are you doing? You know how to do it better than that kind of thing. Some people you gotta be like, all right, sis, come on, do like me. You know, and do it like right in front of them and show them, and they're gonna be, and grin at them and talk to them and be like, and they're gonna go and mimic you. Some of them, you just kind of bullshit with them while they're doing it and put your hands on them and, you know, and raise their arm up a little bit while you're talking to them about whatever's going on. And I just say, go a little bit more like this, you know, so you just kind of gotta read the individual while it's going on.
Which is like, you're building clinical judgment by doing that, and that does come with time, and you get better at working with different personalities and different people. But that's the cool thing about you guys in this job and getting experience is like, you have to do that and figure that out whether you've teched before or whether you're a brand new first aid PT. You know, so the sooner you are able to go through that process and like read people and like do that positively where the patient is on board too and is like, oh yeah, thank you, or like, oh yeah, you're right, I needed to. You just become an even better and better clinician. So I'm totally cool with you guys practicing and gaining those skills, because that helps all of us in the long run. And that's where sometimes you guys, if you've been the ones that take them through NPA or the exercises, then you know, like, okay, I know they struggle with the swims particularly, and that's the one that I want to hone in on today. So yeah, I might let them get a little, those last 2 reps of the pinches. Should I have said something? Maybe, maybe not, but I'm gonna follow it up on the swims. I try not to be too much of a drill sergeant on every itty bitty one, especially because some people like that, but most people get frustrated. So think of the flow sheet as a whole, and then like, okay, especially if you worked with them before, where do I want my perfection to be? And then I say, cue and go all in on that. And if you don't know that, all valid questions to ask the clinician, because they do. And there's majority of the time that it's like, okay, I want you to do Patrick step with them. Can you watch for? When a clinician asks you, can you watch for? That's what they're wanting to be perfect. Because I know I've heard everyone here say that from time other questions or stuff you guys wanna go over if I'm here? And we got into Payoff press and stuff too, so I don't care about time.
The one over there, the lap pull down one with the black things,
Yes.
I don't understand how to do that weight. Like, is it just one side and someone says like 10 pounds? You know what I'm talking about?
Yes, I think that if it had, can you walk over, is that cool, crew? So, these in general, without any weights on either side, is 5 pounds. It's just like with the sled, that whatever we document is on top of that. So if it says lat pull down 0 pound, you're like, wait, how do I zero this out? That means no weight on either side. Whatever is documented on there is what they have added to each side. So then, but to answer your question of if you know if it's one arm or not, I would assume it would say single arm, and it would be whatever weight is just on the one. If it says lat pull down 10 pounds, then I want 10 on this side, 10 on this side. No, sorry, 5, for a total of 10.
Okay. And can I actually see the form? Is it just that, like, the back form, so like under it?
So there's 2 ways to do this, and I've seen both ways. If we want to do seated or standing. So I'll show you standing. For me, I don't want them directly under it, especially if they have some kind of impingement and such, because it calls for such strict abduction. I want them to be in the plane of scaption. Are you guys familiar with that? So that's about 45 degrees, as if you were a V. So depending on the person and how long their arms are, is going to depend on how far out you go. So for me, scaption is about there. I want them to start at the top. You have a little bit more core work. I don't want any of this wiggly. And I like the same cue of elbows to back pocket. Full stretch at the top and back. If it's someone who is hypomobile, they will come here and want to do something like this. Cue them for more chest up. So instead of working with, okay, where do I go here? Chest up, then go. That makes sense?
Yep.
Okay, so that's standing. Seated, then I'll take this bench. Seated, I think, is a little more annoying to set up because you're trying to find like where's the middle. And if you have a particular patient and they're like, that's off. So I kind of like standing better. But anyways, same thing. Yeah, see this bench is off, whatever. Whatever the scaption plane is, I'll have them stand, find where they need to be. Like this is too far back, right? That's going to be more of like a row or a pullover. Find where scaption is, then have them sit. And then elbows to back pocket. Same cue of like keeping chest up. Here is when people want to lean over and use more of like deeper back muscles. But does that make sense? Yeah? Questions on that? So I think the key with that, find their scaption, then have them.
And then they say weight for this, just, it's total weight probably.
Yes,
So 10,
total weight.
5.
And extras is all in there, this box.
If they got put away correctly.
True
And
that.
not just like some side.
True that. Yeah. Any other questions?
Kind of off topic, but like,
Yeah.
say if I were to like bench, would make you need to do like a good warm up for that? Or,
Yes, they're gonna be a great warm-up anyways. I would just make sure that you didn't like burn out all of your endurance there before going and benching, especially if you're gonna be doing like heavier weight or anything where the reps are gonna be below like 6.
Gotcha.
I like kind of more of like an upside down kettlebell or like banded, like we talked about. That's gonna be a better warm up specifically for pressing because you're practicing pressing.
Gotcha. And then for the kettlebell, so there's a bang around your arm, with 2 kettlebells?
Just one in the, so you're resisting and making sure that you're keeping external rotation the whole time that you're pressing.
Are you holding kettlebell?
you. It can be fun. This can be fun. I kind of like it for a pec stretch off of a bench, but you can do it from the floor or from the, oh, let's see. Yeah, let's do 35s. That'll be fun. But Andy does have this one on like a majority of his bigger stations. So, whoa, sorry.
Whoa,
See, bench. And the key is to keep wrists in line with elbows the whole time. You'll see them on his tray do this. Try to keep it out. Go. You can use whatever weight of kettlebell. It's challenging but doable. For most patients though, it's gonna be more like 5, or the soft kettlebells are a little bit more forgiving. If you saw whenever I first started, like it starts to go, then wants to go. Like this isn't a very like evenly weighted kettlebell because it's adjustable. So, yeah, so Andy will have them do that off of like the plinths back there. I'm trying to think of if we have anybody right now that does this.
I don't think
But it's great for anybody who has issues, like pain or issues with like push-ups or pressing of any sort.
Gotcha. Maybe some of that one.
Yeah, it's great. Yeah, it's a great way to warm up and make sure that your rotator cuff is activating through the full motion. So, yeah.
I like that you brought up specificity too, because I don't want to just like doing band work. I'm like, I'm not doing a bench right here. I mean, I am, but I'm not. You know what I mean? It's not as
Yeah.
specific as a push.
And especially with something like that, if we're talking like patient having problems with like weightlifting or like, hey, I'm trying to do better at the gym, like you need to train the patterns that they're using. So that's why I'm usually a pretty big fan of like bar work. Like if you're wanting to barbell bench, let's just do light and make sure we have a good form with that. Also, the underlying, the thing that gets overlooked is like full chain. By doing that and doing this, I just prime my wrist, my elbow, everything goes in line because it's about to be loaded all the way through. So as far as warm-ups and such go, thinking of that will help you choose things that aren't so accessory. And then you're like, dude, I just warmed up for 30 minutes and I had an hour to work out. And I think that that's where even here in PT patients get frustrated of like, I'm just trying to be able to do my hour workout with no pain. You just gave me 2 workouts, so if we can double dip of some sort, then that's like beneficial and such. So hence like loading full chain is going to help you get closer to your goals faster, I guess.
When you say full chain, what does that mean?
So if I was benching, I could warm up my chest like what Cam is saying.
Oh,
of
so
like
say-
this, all I did was warm up my chest. What I just did with the kettlebell,
I'm warming up everything you had
Mhm.
used.
in the pattern it's about to be used in as well. Like I just practiced that whole plane of getting elbow down and back behind me and pressing up. So now everything is ready to go so that whenever I hit my 135 or whatever, okay, it's not like, ooh, I'm warmed up here, but now my wrist is hurting.
Oh, yeah. Makes sense.
Yeah. So, yeah, it's really fun whenever we can get the patient to that level and then we can get into all that. That's like my favorite. Yeah. We've got a couple right now that are fun like that. Because I'd imagine you guys are all more interested in like that aspect of PT. You're like, okay, I've seen a bridge. I've seen a ball squeeze. Like, okay, can we like move on and go on? And that's all dependent on their goals. You know,
At
I
some
don't think-
point in time, we'll do training on stretches and warm-ups and stuff. So that, because I feel like sometimes on the warm-ups, we get a little stuck and forget to pay attention to the cueing and stuff that needs to happen with the warm-ups, and we get a little laissez-faire on what happens with the stretches and warm-up exercises. And we forget what we're supposed to be looking for on that too, so we're gonna training on that and kind of go, oh wait, like, it's really abs.
your point, a lot of people think that they're doing it right or doing the right sequence when in reality they are not, and that's why they're having
Because
issues.
they're.
Right, they're in our, yeah,
They come in twice a week for physical therapy, and, you know, they don't even think about the fact that they have to
yeah,
focus on their abs, and by Wednesday, and they thought about it on Monday, but by Wednesday, they're just going through the motions of this. And, you know, and they're not even thinking about the fact that they need to focus on.
but I think to your point with that, one, you guys learned what a NARP is today, so you did
Yeah.
learn something, okay? But two is, as a tech or clinician or whatever, being confident in telling someone like, no, that's not what I mean, or like, no, that's not how I want you to do that. You guys are okay to say, no, that's not how I want you to do your bridge, put your foot out. So I think that there's times where like, okay, I said we're gonna do table stuff, and they just started doing whatever, and you can tell they kind of know the flow, or like, cool, they're hamstring stretching, but then they just went to this, and then they did this. Feel free to say, hey, like, are you wanting to do this in a specific order? Do you have a particular, like, the patient that comes to mind for me is Pat. You guys met Patty with the shoulder. She likes to do it all based off of if she is standing, sitting, or laying down. Okay, great, awesome, but there is no reason that you guys can't ask, but, because I know there's times that you guys have seen her and been like, well, she's doing her, what am I doing? She still needs to be cued. There's still times you're like, Patty, that's bad form. Like, even if she's not doing it in the order that we traditionally do, we need to take it exercise by exercise and say, okay, I can give you a little bit there, do it in the order you want, but when we do it, let's do it as correctly as we can. And she's nice, you guys have talked with her, she's open to that, she wants the feedback, but there's that upfront of like, that, I know there's that moment of like, okay, we're going off the beaten path, do I just fully let go? And this is me telling you, you don't have to fully let go. And if there's ever a time that you're questioning, or you're like, always ask, you can always, even if it's not somebody's patient, or you're working with Nick, but he's in the private treatment or whatever, it's an easy, Andy, is this looking right? Do you want me to, we're all very open and willing to do that, whether it's a patient we are treating right then or not, so. More questions, the better.
Remember, we're all here to get the patient better, not just have them in some infinite loop of hamstring surgeries.
God, because they'll sit there for 5 minutes sometimes. You guys are all really good about having watches and like for real timing. I'm bad. I'll call myself out on that. I'm like, it's been time, you're good, you know. But having like a timer and a watch, like that does help a lot as far as cutting that down.
Yeah, you got that, and I really appreciate that.
Yes, me too. Thank you for timing for me.
Blair should hire you as a PT.
Yeah,